Yes, and you're live.
The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon. This is Eric Goff-LaRude. I'm Senior Vice President and Director of the Substance Abuse, Mental Health, and Criminal Justice Studies Department at NORC at the University of Chicago. And I will be conducting a webinar this afternoon on the future of Hospital SBIRT, or Screening, Brief Intervention, Referral, and Treatment. This webinar has been put together so that participants in the Hospital SBIRT initiative and others who are interested in the development and provision of screening, brief intervention, and treatment in their hospitals will have an up-to-date set of slides and materials that can be used for working in their own hospitals or working with other hospitals to build or to show the business case, the clinical case, and the direction of current hospital screening, brief intervention, and treatment activities as they stand at a national level, and then with an example of how they apply in one state, in Colorado. We can make these materials available to you on the Hospital SBIRT website. That site is Hospital SBIRT webs.com. And this will be a 1-hour webinar. If anyone would like to raise questions or to have further discussions at the conclusion of the webinar, we will stay on the line and entertain any questions that come up. If anyone would like to listen to this webinar or refer back to it, it will also be posted on the Hospital SBIRT website. Let's go, and this may be a fairly quick run through some materials that you have already seen. Hopefully it will raise some questions and provide some information that you can use in your own practice. Now, substance use disorders and risky use of alcohol, drugs, and prescription pain medication is a significant public health problem that is associated with mortality, substantial mortality and morbidity. Almost 100,000 deaths per year in the United States are caused by or complicated by alcohol use. About 16,000 deaths annually from illicit drugs, and a cross point occurred within the last 3 years, I believe, in which overdose deaths from controlled prescription drugs, primarily opiates, has exceeded the number of deaths from all other illicit drugs, reaching about 20,000 deaths in 2010. In addition, substance use is associated with substantial increased morbidity, and the chart below shows the increased risk associated with the average ingestion of 50 grams of alcohol, or approximately 3 drinks per day, or 100 grams of alcohol, or approximately 6 drinks per day, on the increased relative risk of several illnesses in which alcohol is implicated. But although this is substance use is a significant public health problem, why should we be focusing on hospitals? There are several reasons why hospitals are critical health care institutions where identifying and managing alcohol and drugs of patients who are coming in hospitalized for medical illnesses or injuries, where opportunistic screening and treatment can have a significant effect. Alcohol, drugs, and increasingly prescription drug use are crowding emergency departments, associated with increased stress on the emergency department capacity, the use of emergency department beds and personnel, and contributing to psychiatric boarding, a problem across the country of patients with psychiatric and substance use disorders remaining in the hospital for extended lengths of time while placement in appropriate treatment is sought. Secondly, substance use is associated with expensive emergency department visits. And for patients who are uninsured or for whom care is uncompensated, the increased costs associated with assessment and management of patients with alcohol and drug problems in the ED can contribute to substantial costs and substantial uncompensated costs to the hospital. Third is that substance use disorders are common complicating problems of hospitalized patients, including increased use of medical intensive care units, higher rates of return to surgery, longer lengths of hospital stays than patients who do not have a substance use disorder. And also that a complicating problem is that patients who have a substance use disorder or a substance use disorder in combination with a psychiatric or a medical condition are at much greater risk of being unstably discharged and returning to the hospital within 30, 60, or 90 days. And later on in the slide deck, there will be some specific references for each one of these major points. This slide, Why Hospital SBIRT, shows what's happened in terms of emergency department mentions of illicit drug use or misuse or abuse of prescription pharmaceuticals in emergency departments, as reported by the Drug Abuse Warning Network, or DAWN, drug-related emergency department visits. As you can see, in 2007, we appear to have hit an inflection point at which there are more emergency department visits associated with misuse or abuse of prescription medications, about 2/3 of which are prescription opiates, than for misuse or abuse of all other illicit drugs. When patients with alcohol or drugs on board come into the emergency department with a mild or moderate injury, they require substantially more treatment, more tests, more lab tests, and interventions than do patients who are matched and who come in with injuries that do not have an alcohol involvement. As you can see on this slide, the report from a study done by O'Keefe et al. Looked at differences in the percentage of patients with alcohol or without alcohol on board in their use of a variety of emergency department services. And you can see that there are substantial differences in ambulance transportation, in CBC, electrolytes, other lab tests that are ordered, chest X-rays, CAT scans, EKGs, urinary catheterization. In each one of these, the costs associated with the treatment of patients who are positive for alcohol, and it's not necessarily alcohol dependence, it is that they are positive for alcohol use at the time of admission, that the costs would be substantial for hospitals and may not be compensated, especially if a patient has no insurance. And the risk, or the relative risk, of a patient who has alcohol on board during an emergency admission, of having previously, in the previous 12 months, sought emergency department care, is about 50% higher for those patients than for matched controls. So you can see that if you screen and treat alcohol problems in the ED, you may be preventing re-injury or reuse of the ED even as soon as within 1 year. Now, this slide shows in the instance of Colorado, of all patients who come in through the emergency department, the proportion by payer who are likely to be hospitalized, who are likely to be positive for significant alcohol or drug use. Out of approximately 1 million emergency department visits, about 123,000 of the 1 million visits will have substantial alcohol problems that caused or complicated their presentation in the emergency department. And you can see that while these are spread across the different types of insurance carrier, that there's a substantial contribution or a substantial number who are likely to screen positive who are uninsured. Now, the column that says annual costs undetected is the excess costs that are associated with untreated medical and injury that patients who would of this panel of 123,000, their medical costs that are in excess of the average for matched controls in a 1-year period of time. The next column, the savings if detected, are the 1-year savings in healthcare costs across all of California or Colorado admissions by payer. And if you take a look at those bright yellow boxes, what we call those bright yellow boxes in healthcare financing is charity or bad debt. So the cost of not detecting the alcohol problems and drug problems of patients who are coming in through the EDs in Colorado, and we could show and have data for every one of the states, is nearly $76 million in the annual costs of undetected patients. And the savings were screening and brief intervention done routinely in all of the emergency departments in Colorado, is a savings of about $15 million in bad debt in patients who would not be able to pay for the cost of their treatment. So where is it that alcohol or drug problems show up as they come into hospitals? As you can see on this slide, which comes from the Centers for Disease Control and Prevention, there are a total of more than 60 medical conditions that are associated with misuse and chronic use of alcohol. Many of those that are over on the left-hand column are injuries that are increased, that are the increased risk associated with use of alcohol. And they tend to be the kinds of conditions that show up in emergency departments as illness, as injuries. And on the right-hand column are illnesses which are more likely to show up in older populations, often with the median age in the 50s, 60s, or 70s, that are associated with chronic use of alcohol. The percentages that are in these columns are the percentage of morbidity or mortality that is associated with use of alcohol. So you can see that stomach cancer, for example, about 20% of those cases are caused by alcohol use. Or gastroesophageal reflux disease, about 10% of those cases. Among patients who are hospitalized, this is in Colorado, these are the proportions of the population who are hospitalized and who have a comorbid substance use disorder, or who are drinking at such high levels or frequency that it substantially increases their risk of having medical complications. The percentages across the top are the percent of all Colorado hospital inpatients who have as their primary payer Medicare, Medicaid, etc. What you can see is that of all Colorado hospital discharges in 2009, that a total of about 350,000 discharges, about 22,000 of them are likely to have a substance use disorder, and an additional about 26,000 also have or would have a risky pattern of alcohol use. Under the charity care, as I just point out here, these patients who have a comorbid alcohol or drug use disorder or high-risk pattern of alcohol or drug use, about 6% of all hospital discharges, are likely to have no source of payment and would likely then end up as a cost to the hospital rather than as a revenue. A reason then for identifying and treating early so that you can reduce the risk that patients are going to be discharged and come back. Now, if you are going to look for where do you concentrate your screening and brief intervention, it's important to look at where the patients are likely to be. And this slide shows the proportion of patients in various settings who are likely to screen positive for high-risk alcohol or drug use. And you can see that in ambulatory primary care or inpatient medical services, general medical surgical services, that it's about 7 to 8% of all patients who are likely to have a high-risk substance use or who are likely to be dependent. A higher rate would be found in hospital emergency departments. What we are finding in the SBIRT grantees is that somewhere, depending on when screening is done, time of day, the intensity of the screening, that somewhere around 20% of adult patients in emergency departments are likely to screen positive. In the trauma centers, the proportion goes up to between 40 and 60%. In mental health ambulatory care, about a third, and then back in psychiatric inpatient, it's about 50% of all patients have a comorbid substance use or high-risk pattern. The next set of columns show of those patients who are who would be screened or who could be screened as positive, how many of them could benefit from a brief intervention, or in the third column on the right is those that probably because of the intensity of their substance use disorder, the comorbidities that they have with a psychiatric condition or medical condition, that more intensive treatment would likely be necessary. And so either the referral to treatment or a negotiated intervention to help them receive brief treatment or more extended medical treatment with medications or and/or intensive counseling. So if you were going to say, where do you go if you have limited resources for screening and brief intervention for alcohol or drugs in a hospital setting? The two most prominent would be in psychiatric units and in trauma, followed by the hospital emergency department. Certainly other services that might also benefit substantially, and their patients benefit substantially. But if you're going to concentrate and have limited resources, it makes sense to go to those places where you have the highest concentration of patients with a need for substance use screening and treatment. Now, this slide shows the crude rates and risks of recurrent acute care hospital utilization within 30 days after the patient had been identified, the index hospitalization. And these are two studies by Forsyth et al. And Rubinsky et al. That looked at rates of reutilization, or essentially rehospitalization or emergency department visits within 30 days of discharge. And what you can see is that patients who had no substance use disorders compared to patients with a comorbid substance use disorders, the rates of reutilization are nearly double in each instance for ED visits or rehospitalization within 30 days. The next set of numbers, the risk of reutilization, is that for any specific particular individual, their risk of coming back into the hospital, if they had no substance use disorder, is about 38%. So about 38% of patients discharged, their risk of rehospitalization would be about 38%. If you had a substance use disorder, the risk of rehospitalization or ED use is over 50%. Given the increased attention that hospitals and payers, including Medicare, have been placing on reducing 30-day readmissions, these data suggest that focusing on patients with a substance use disorder could be very, very helpful in reducing rehospitalization risk. This slide probably best demonstrates that I'm not the best at constructing PowerPoints, but it combines a couple of studies that are cited at the bottom here. First is, this is a report in the Veterans Administration hospitals of surgical complications, infection rate risks, long length of hospital stay, return to intensive care units and surgery of patients who had scored as high risk for alcohol use at some time in the 12 months prior to their hospitalization. And what you can see is that those patients who had a low audit score or alcohol use diagnosis, anyway, a low audit score on the audit C, the 3-question consumption questions, had lower lengths of post-operative hospital stay by about a day if they used the ICU they had about 2 days less of ICU, and their probability of return to the operating room within 30 days of discharge was half that of patients who had a high audit score. And you can see in the slide below, the lower half, that the greater the amount of risk, the higher was the risk of postoperative complications. Now, this slide shows that there is a substantial gap between what we know are effective treatments for alcohol and substance use and what actually happens in practice. This is a slide from a report, a study done by Kerr, McGlynn, and other researchers at RAND, who profiled the quality of care of more than 25 medical conditions, looking at what is the concordance or the agreement between what is the professional standard of practice and what actually was delivered to patients with these conditions. And this report, those little spidery figures, show that for the 12 communities that were made up the study sample that is representative of the quality of care given to all patients across the U.S., that in every instance, the quality of care, the gap between what's known and what's done, was the greatest for substance use, screening, and treatment of all of the 25 conditions that they studied. Patients, for example, as we showed, between 40 and 60% of hospitalized trauma patients have a significant alcohol or drug problem. Only 15% of patients who were traumatically injured or had hepatitis and were hospitalized had any notation in the hospital record that they had been screened for risky alcohol use. So while we know the size of the problem, the number of folks who are coming into the hospital and coming into the ED with comorbid alcohol or drug problems, there's a huge gap between what's best practice or good practice and what actually is practiced. Current and near future developments. What's going on right now? There are a number of things which are very positive that are leading us to have hope that the next area for widespread adoption of alcohol and drug screening and brief intervention will be hospitals. There are evidence-based practices that are growing from research and from practice experience about the effectiveness and the population for which screening brief intervention appears not to be as effective. The reimbursement rate is improving. Training and practice support networks are strengthening. There are accreditation requirements as well as performance metrics and incentives to report. And hospital electronic health records and health information exchanges are coming into widespread practice where screening and brief intervention is being built into the EHRs. So we'll go into each one of those briefly. Those of you who have been working with us on screening and brief intervention in hospitals or doing SBIRT in other settings are likely very aware of the large body of research which supports the effectiveness of screening and treatment for alcohol and drug problems. Now, it's important to point out that while there is there's positive evidence in a number of studies, not all studies find that screening, brief intervention, or treatment that is hospital-based is consistently or uniformly effective. So we have a developing evidence base, but it's not consistent across all studies. And so, among others, more studies are necessary in order to increase the effectiveness of the interventions, to determine under what circumstances can screening and brief intervention be effective, and for what populations, individuals, is it ineffective, or it needs to be changed or modified to become more effective. I'm not getting, there we go. Here's another demonstration of some of the studies that have demonstrated cost savings of doing screening and treatment in medical settings and in hospital settings. And we are also now developing a growing, very current evidence base coming out of Hospital SBIRT, or the Center for Substance Abuse Treatment SBIRT programs. This one coming out of Denver General, that is showing that the applied practice experience growing from the SBIRT programs and from diverse programs across the country are also showing the kinds of impacts that some of the more tightly controlled research studies reported earlier. But also convincing in another way is evidence coming from insurance companies. This slide shows the impact of initiating medication treatment for alcohol dependence, as shown from medical paid claims by a large insurer. What the insurer found in the 1 year following the initiation of treatment for patients with alcohol dependence with 4 different medications: Vivitrol, the long-acting naltrexone, acamprosate, oral medication, disulfiram or Antabuse, and naltrexone oral, is that in the 1 year following initiation of treatment with these medications, behavioral health inpatient days, I'm just looking, say, at the Vivitrol or the oral injectable naltrexone, was decreased by 30%. Also, medical inpatient days per 1,000 patients declined for each one of the medications. Behavioral health intensive outpatient days increased. Psychiatric visits increased. Psychotherapy, non-psychiatry, non-MD visits increased. ER visits were inconsistent. For one of the medications, they declined somewhat. For the others, they were neutral or increased slightly. But what's important here is the overall shape, which is that you had a movement away from intensive crisis-oriented services, inpatient and emergency department, and an increase in ambulatory care, preventive and care management, and the overall savings, the money that the insurance company got to either put back in its pocket or gave back in order didn't increase their rates, was between 16 to 35% net medical cost savings in the year following the initiation of treatment. This begins to start making sense both clinically and financially, a business case, that initiation of effective treatment begins to move the shape of care away from crisis services and towards better managed care. This also would be an important point for accountable care organizations and patient-centered medical homes, where you have better care over an episode of care rather than sort of the disjointed, fragmented care that we currently have. I'm going to go through a set of slides very quickly here, but they are in the slide set, would show from a different database what the experience was of patients who had an alcohol dependence and then later an opiate dependent set of data. After their initiation into one of 5 different types of treatment. This is not a controlled study. What this shows is for patients who are identified as being alcohol dependent and who are started on depot naltrexone, oral naltrexone, disulfiram, acamprosate, or who were started on a drug-free, non-medication treatment, the annual cost, or the 6-month cost for, hold on, let's go back. I think I missed a slide here. Here we go. For the number of days or visits for detox rehab, for alcohol-related inpatient, and for non-alcohol-related inpatient. What may be surprising is that in the drug-free condition, patients who do not receive medications, but may be referred for non-medication-based treatments, their rates of detox, of alcohol inpatient, and of non-alcohol inpatient treatment was significantly higher than for medications. The costs, not surprisingly, similarly showed the same pattern reflected as in the number of visits. And the overall costs for the 6 months, as you can see, for 3 of the conditions, the depot naltrexone, oral naltrexone, and disulfiram, were significantly lower than for acamprosate and drug-free. This was for alcohol patients. We find a similar pattern for patients who were opiate dependent, including prescription opiate dependent, in their use of patients who were in the drug-free condition, who substantially had higher rates of detox, opiate, inpatient, and inpatient others. And not surprisingly, their costs are quite similar. Overall, the treatment costs in the 6 months following the diagnosis, methadone and drug-free were significantly higher. Now, the next set of slides we're shifting to how do you get paid for screening, brief intervention, and treatment in hospitals. And these slides come from some really exciting work that is being done at the Oregon Health Sciences University and were shared with the Hospital SBIRT group by Joseph Hurley a couple of months ago. And these screens and more can be found at the sbirtoregon.org website. And what I wanted to show is the growing base that for insurance reimbursement that is developing for hospital and for other settings for reimbursement for screening and brief intervention. So in the case of Medicaid, these are the codes and the likely reimbursement rates. For screening only, there are codes which are available. All of these, by the way, are built into an electronic health record. So this one shows, this shows Medicaid. This is the commercial insurance, Medicare. And what I think is really exciting in Oregon, and we're hearing in a number of places around the country where hospitals are building into the EHR's clinical support system the kinds of questions that routinely support screening and brief intervention, and that also then populate a billing record that can go in and be submitted as a claim. Again, this comes directly off of the Oregon SBIRT website. There are other reimbursement codes that can be used And I think, while not so much hospital-based, but pretty good for hospital ambulatory care, would be ambulatory clinics, would be the new Medicare codes that have been just recently introduced, the G0443 and 442, which are prevention codes which require no copay or coinsurance from the patient, are 100% reimbursed by Medicare to the provider. These are not available for hospitals or for EDs, but can be used for hospital ambulatory clinics. Another really important development is that there are training and implementation support networks that are growing out that support hospitals to implement SBIRT. The big Brief Intervention Group Hospital Network, of which this webinar is one of our activities, is a collaborative which currently includes more than 200 hospitals and provides TA training and mutual support, including a lot of sharing of experience, best practices, and challenges. We have monthly calls, of which this is one of our monthly all-committee calls, and they are open, free, and the more individuals and hospitals that participate, the greater is the ability that we have to have an impact across the country. And here is the website, as I mentioned a couple of times, where we will be posting this webinar and have a tremendous amount of other stuff that has been put up there and has just been revised, in fact, by Misty Story. And I strongly recommend that you take a look at it. It is a terrific resource. In addition, SAMHSA's SBIRT grantees form a network. 3 additional states have been funded this year, and I believe in total there are 21 states who have received statewide funding. 17 medical schools have received funding to train residents, 15 college campuses, and I have here the contact for Colorado, and we are hoping to facilitate contacts between the SBIRT grantee leads and the state associations of healthcare quality, the quality improvement professionals that are operating in each one of the states. We also hope to make the same kinds of links between the SBIRT grantees and their state hospital associations. The Emergency Nurses Association also has set up a mentors program. Cindy Perhatz has been leading that effort, and the slides show where the states are, where emergency nurses are taking the lead in developing and sustaining SBIRT in their EDs and beginning to move it into other services in the hospitals. Accreditation and performance metrics is another important growing source of positive movement in support of SBIRT. The American College of Surgeons Committee on Trauma has required for several years now that Level 1 and Level 2 trauma centers, to retain their accreditation, demonstrate their ability to screen and provide brief intervention. There are 203 Level 1 trauma centers. Those are the most intensive and high-volume trauma centers, and 271 Level 2 trauma centers in U.S. hospitals. The trauma centers and the trauma surgeons have taken the lead in highlighting the importance of SBIRT as a preventive intervention to reduce the frequency of re-injury, re-traumatization, and death. The Veterans Administration mandates screening for risky alcohol use using the Audit C at least annually. The Joint Commission for the Accreditation of Healthcare Organizations has since 2011 required that all 320 psychiatric hospitals report annually on a set of hospital-based psychiatric inpatient measures, one of which includes routine alcohol screening, alcohol and drug screening. This is an option for general hospitals with psych units and is mandatory for freestanding psychiatric hospitals. Also, as many of you are aware, the Joint Commission has developed and since January 2012 has encouraged hospitals to report on 4 alcohol and drug screening, brief intervention, treatment, and follow-up performance metrics, and a companion set of 4 tobacco measures. They were adopted in 2011. The National Quality Forum reviewed the measure set in spring of 2012, and the Joint Commission is collecting additional data that will be submitted in fall or early winter to the National Quality Forum. It's important to note that the approval of these measures by the National Quality Forum would pave the way for the Center for Medicaid and Medicare Service to include as in their reportable measure sets for Medicare the Hospital SBIRT measures. This comes from this quote comes from the Federal Register, in which it basically says when the Hospital SBIRT measures are e-specified, meaning electronically specified, so that they can be reported in electronic health records, and are approved by the National Quality Forum, that CMS intends to include these measures in the hospital quality improvement, the hospital payment incentive. So this is a very positive announcement, and it came out just several months ago, in May, of CMS's intention to adopt these measures. I have a set of slides that just show the 4 measures. The first is an alcohol screening measure. The second is a brief intervention measure for those patients who screen positive. Third is a treatment provided or treatment offered for patients who are identified in the hospital with an alcohol or drug use disorder. And the Joint Commission is going to be testing whether it makes sense to concentrate in a smaller number of services or hospital-wide this measure of initiating treatment for patients who are identified with an alcohol or drug use disorder. And then finally, a follow-up measure, which is within 30 days, patients who have a drug use or an alcohol use disorder are followed up by the hospital, or attempts are made by the hospital to follow up these patients. The Joint Commission is now testing the use of this measure, or the focusing of this measure, just on those patients identified in the previous measure, those patients with a substance use disorder. Those were the ones who would be followed, cutting down the burden and concentrating on those patients who are at the highest risk for 30-day readmission. Now, where should we be looking into the near future? And this is a little bit of maybe rose-colored glasses, but speculating over the next couple of years, what do we expect will be happening? First is, I think that we're going to see greater standardization of what we mean by screening, brief intervention, and treatment in hospitals. A greater agreement on a common question or questions that can be used routinely as part of intake processes, likely given the lead that we already see from the Veterans Administration, from employer groups, and from the many of the SBIRT programs. We can expect to see probably greater agreement on the use of the audit or the audit C as a pre-screener a 1 or 2 question drug use questionnaire question coming out of research being done by NIDA, and 1 or 2 tobacco questions. Second, we can expect to see greater adoption of standard protocols for SBIRT, also being used for other routinely performed protocols, for, say, depression and suicide screening, for domestic violence screening and treatment, for diabetes, weight management, and diet control. That the standard protocols that are being used now with motivational interviewing for alcohol and drug SBIRT fit very nicely into other nursing and health education protocols that are being used, and so it becomes generalizable rather than something that's standalone. And we're seeing, and I think we will see more of, interest in the development of professional standards of care coming from some of the lead groups that are provide the kind of care management across medical conditions. So in nursing and social work in particular, and then also other medical professions. But I want to particularly highlight the very extraordinary work that's being done in nursing, led by, among other places, the Emergency Nurses Association, the International Nurses Society on Addiction, and the psychiatric nurses, who are highlighting and working to develop as a standard of practice for nursing that screening and brief counseling and management for alcohol and drugs is good nursing practice. Similarly, there is work that is being led by the Center for Clinical Social Work and others around the development of standards of practice for social work. Training availability is the next, I think, really exciting area. Among other things, there has been the development of remote trainings, some very good things that have already been up and I hope are widely known, that NIAAA has developed on rethinking drinking and the clinician's guide, where there are a number of videos, some very good work that Rich Sates at Bernstein and others at Boston have put out online to train physicians and other medical practitioners using web and video links. And I think some very exciting stuff that Jan Pringle and out of Pittsburgh School of Pharmacy and Jenny Probanik from MedRespond have been developing of interactive, highly interactive, gaming-based training programs that can be taken over the internet and adapted for every medical profession and health profession. Discipline-specific, so that for dentists or for HIV/AIDS clinics or breast cancer clinics or nurses, that the training is available that looks, feels, and relates to the problems and issues that confront that health profession, and the development of competency standards and testing, the demonstration that a clinician can show the SBIRT skills. We see new financial and clinical accountability mechanisms developing. The accountable care organizations, we have 32 pioneer accountable care organizations, and now CMS has identified about another 100 where primary care practices or primary care practices in hospitals receive incentives from CMS for care of entire episodes of care or for populations, which then increases the value of assessment and management of alcohol and drug problems. Patient-centered medical homes are another place where crucial and central to a patient-centered medical home is the ability to screen and manage the mental health and substance use problems of patients. And we see more and more incentives that are being developed through the inpatient prospective payment system rule for Medicare and the bundled payments that not just government but also insurers, private insurance, is working on, that include bundling together the kind of care management that SBIRT is a good example. We see electronic health records and health information exchanges developing pre-screening and management supports to avoid surgical complications, to avoid drug-drug interactions, to avoid the potentials with opioids and other psychotropic medications. Research is developing, and some extraordinary research is being reported and is underway with nurse-led Hospital SBIRT. Important work that's being done identifying high-risk, high-cost inpatients with comorbid substance use disorders. Research on drug SBIRT, which is now not as well developed as alcohol. And more focus on hospitals themselves, not EDs. There has been quite a bit, trauma centers quite a bit, but in other medical services. And then we will see, I think, the development of a stronger base of community substance use treatment that is coming in through primary care, through community health centers, and the medical treatment of addiction through the use of medications. This is a very, very quick tour through the current business and clinical case for screening for risky alcohol and drug use, treatment of these conditions in hospitals, the current practice, some of the exciting developments that are presently underway, and what we think will be in the near future some very important developments that will help bring SBIRT into the routine practice of hospitals. As I said at the conclusion of this call, I will stay on the line and would be happy to answer questions and to further explore any of the issues that were brought up. But at this point, I'd like to thank everyone for participating, and I look forward to working with you on the Hospital SBIRT initiative. Please come and join us monthly on these calls. The calls are always at this number, 218-339-4600, and the access code is 426443. And I encourage you to come out to the hospitalsbirt.webs.com website, where you can find this webinar and other webinars and extraordinary materials from many researchers and groups around the country that are posted on that website. So thank you very much, and look forward to working with you in the future. This is Eric Goff-LaRude from NORC at the University of Chicago.